This is the 6th and the final one. We're going to audio record it. If you're not happy, be careful what you say or leave. And then they'll be available to you afterwards. We're going to have 2 speakers today, and I'm going to introduce them in a minute. But if you would like to use the chat function for the questions and answers, and then at the end we can try and let you ask the questions in person if we don't have too many. What else is there to say? Yes, you'll be muted, but of course mute yourself between talking. And I think that's all the notices, Sarah, is that right?
Yes, so just say it's the final webinar. All the first 5 recordings are all available on the COMET website, and today's webinar should be added tomorrow, hopefully.
Sarah's been providing brilliant support for all this. Thank you for that. And I'm Jane Blaisby. I'm on the COMET management group, and it's my pleasure to be hosting this seminar today. And Paula, who leads the COMET management group, Paula Williamson, is also online, as you can see. So first of all, I have the pleasure of introducing you to Jamlick, who's calling in from Nairobi in Kenya, where it's 4 p.m. in the afternoon and it's warm and sunny. And Jamlick is a PhD student at the University of Liverpool at the moment, being supervised by Paula and a team of people. And he's going to be telling us, he's in his first year, so it's always a bit stressful giving talks, especially in your first year. Pharmacist by background and got some epidemiological training. And Jamlick's going to be telling us what he's done and what he's planning to do in his PhD. Thank you, Jamlick. I'll hand over to you and share your screen. And questions in the chat, as I said to everyone, type them out.
Thank you very much, Jen. I'm going to share my screen. Let me just switch off my video so that it doesn't interfere.
I can't see your slides yet, Jamlick. Can anyone else see them?
No, not yet.
Are they there?
Yeah, they're coming. Thank you. Well done.
Oh, sorry for that. So thank you and welcome everybody to this session. As Jane says, I'm Jamlick Karumbi, currently based in Kenya, Nairobi. I'm just going to take you through a piece of the bigger PhD work that we are undertaking through the University of Liverpool under the supervision of some of the people who are in this call, including Paula Wilson and Sarah. So in terms of the topic, it's to do with how do we involve more people participating in course development from the LMIC settings. So this is a presentation of work from the systematic review, which, as you all understand, is usually the first step towards kind of any understanding any area. So for the purposes of all of us being on the same page, core outcome sets have been defined as the minimum agreed standards that should be measured and reported in a given clinical area, and not necessarily just clinical area, but also expanding to other kind of research works, including some of the routine work that happens within the hospital setting. So they mainly consist you having a domain of what do you want to measure. So for example, if you're looking at a given disease area like malaria, if you want to look at morbidity, but then also looking at how do you want to measure that kind of outcome. So course development has been going on globally for a while, and it's only that in the last few years is when people have now tried to really bring in things together and also provide some guidance on how to develop. But really, it's something that has been happening worldwide. But from the way you can see in that map, it's mainly been concentrated in Europe and North America and probably in Australia. But if you look at the other areas, especially LMICs in Africa and South America, there is not much that has been going in there, and that's why this kind of work really is important for us to try and understand how do we bring everybody together for this kind of work. So ideally, as I said, we are in a global connected village whereby you need to look for research in a more global perspective, so that then you avoid duplication of efforts from other people, and also it makes research output becomes more applicable when you are able to develop it that with a context of different settings. So there is the COMET initiative, which was started in around the year 2010, and it maintains a database of some of the outcome set studies, and also it enables somebody to register a outcome set study before they start off, and it really helps to bring people together such that if somebody in a given area of the world is trying to develop the same outcome sets, then it enables to provide for some kind of collaboration, like we saw in the recently developed outcome sets for the COVID-19. So specifically for this work, we just aim to describe what are these outcome sets that have had participants from LMIC, or what has been happening in the LMIC setting when looking at outcome sets. So like any typical kind of review is that you look at the studies, you first give an inclusion criteria. We look at the studies which we're talking about a methodology of determining what outcomes needs to be researched on, or what outcomes we need to be tracking for whatever purposes, be it quality improvement and the rest. And these studies had to be published in the COMET database. We looked at it until the end of 2019. For those that have been published thereafter, we are there is work ongoing that will be reported in a different arena. So the data we are looking at is what was the scope of these studies, who are the participants in terms of are they patients, are they clinicians, who are they, and what are the methods for consensus building, because consensus building is a key thing for the way you agree on outcome sets. So looking at the database, we were able to find about 370 published outcome sets, and out of these, 75 of them, that's about 20%, had included participants from low middle income countries. Digging deep into that and just trying to see when was this done, and in terms of looking at it from a perspective of these studies had been published since the year 1982. So looking at all the way from 1982 to 2014, out of the 229, only 15%, representing about 35 outcome sets, had LMIC participants. But in the last 5 years, and out of the 141, 28% or about 40 of the outcome sets have had participants from LMICs. But then the interesting thing is that you would think that they are coming from all over the way we define LMIC as per the definition given by the various entities, including the World Bank. But there are three main countries which are driving the participation of development these outcome sets, mainly from Brazil, China, and South Africa. When you try to just compare a few things in terms of the scope of the outcome sets between those that have had participation from the low in LMIC, so to say, is that in the last, a higher percentage have a specific aspect of looking at COS rather than defining the outcome set as part of a wider trial design. So additionally, we are seeing a higher percentage of the LMIC outcome set, so to say, being more for research and practice. And this is really useful because previously outcome sets have been developed mainly focusing on research, but we're seeing a more traction being gained in terms of moving towards also having them for the whole continuum of research and practice. In terms of these, who are these people who are involved? When you look at across the two levels, is that mainly clinical experts have been the people who have been involved in this, but also public participation. It seems like a good chunk of the outcome sets with LMIC participation had people from the LMICs, but actually, if you look at those papers, is that the public participation we are talking about here, that's the patients or probably the public representatives, were just people from high income settings. So it's only that LMIC people are included there as clinical experts or research experts. So we also try to just look at, have we had any outcome sets initiated from LMIC settings? Out of the 75, just 4 of them, 2 from China, and you can see they are looking at different aspects. So one on infertility and the other one on bone injuries. And then one from Sri Lanka looking at epilepsy in children, and also another one from Philippines. The key thing is that a majority of these, except the Philippines study, is that they have been done in the last 5 years, where we have seen a bit more development of outcome sets using or having people from the LMIC settings. Interestingly, 0 from Africa setting or from the South America setting. So what are the disease categories that people are looking at? So overall, like you would look at the global burden of disease, we still see issues to do with the neoplasms of cancers or issues to do with the cardiovascular disease still rank as some of the things that people are developing outcome sets for. But also additionally, towards the tail end, you can see that more people from the LMICs are more interested in health system kind of outcome sets, which can probably reflect some kind of the research that people from the LMICs are more interested in trying to improve the health system for service delivery or whichever other area. Consensus building process, it's very similar across the board. Most of the people are using mixed methodologies with a slightly higher percentage from the LMIC, again, which can be explained by having being a little bit newer outcome sets. And also additionally, we have had a few developments in terms of guidance for developing outcome sets. So it's not really surprising, but it's a similar process where people are using a mixture of these methodologies, Delphi, consensus, in terms of conferences and also semi-structured discussions. But then we also got interested to know if you want to include people from a wide range of perspective, are people trying to translate some of these materials that will be used during that consensus building process? So out of the 75 that had involved LMIC participants, where I would expect the Portuguese language from South America and also probably Chinese and some of the local languages in Africa, only 4 had translated the materials to non-English or local languages. One on acute diarrhea, another on infant colic, another one on constipation and type 2 diabetes. But interestingly, all these translated these materials into languages that were more understandable to participants or patients from the high-income country settings, such as Belgium, Denmark, and the rest. So then, what are we saying? We're saying that, yes, there's some progress that's happening in terms of people participating in development of outcome sets from LMIC setting. However, we probably need to have a better prioritization of the kind of outcome sets so that it can reflect the burden of disease, because as you look at LMIC settings, some of the infectious diseases still rank quite high, and neonatal issues are still quite ranking high. So it would be useful to see maybe outcome sets developed for those kind of diseases that then would enable people doing research in this area to be reporting on them in a better way. Then we also need to explore how to initiate the development of these outcome sets from a range of LMIC settings. Maybe do we need to do more language translation? If yes, which language would make sense? Would the methods work, especially in these times of COVID, where probably having face-to-face consensus building meeting may not be having? So there are several issues that we are going to look at, and this is now what will lead to the next step of the work, whereby then we are going to invite some of you who are on this network to just find out more in terms of what can work and what cannot work, in terms of what has worked before, what can work going forwards, through an online Delphi kind of a survey, which will be floated through some of the channels that are available, including the Global Health Network. So I think that's what I wanted to share with you. It's a bit brief in terms of where we are at now. Thank you.
Thank you, Jamlick. Thank you for unsharing your screen and for covering so much ground. Wow, amazing piece of work. Well, we have got time for live questions and or written questions. So over to you all. Can't see your faces, of course. If you want to turn your video on, that'd be great. Oh, here we go. Here's a question from, do you want to ask it yourself, please? Somaidi. Sorry if I can't say that correctly. If you want to unmute, that would be brilliant.
Yes, thank you. Thank you for the great presentation. And I was actually wondering that if you have looked into whether the core outcome sets which have been developed with funding have better LMIC participation or better patient participation compared to those which are not funded for their development. I think that would be useful to know in terms of resourcing and planning for others.
Thank you. Jamlick, did you get that?
Yes, I got that. Whether we have looked at the issues of funding and whether it affects participation from the LMIC. Indeed, that's one of the questions we want to focus on, those 75 authors of the 75 outcomes to just find out was the issue of funding one of the key things that made them decide, yes, I'm going to include this. So it's one of the areas we are going to explore forward, but it's not been a major issue, so to say, in terms of what has come out in terms.
Okay, and Sumai Deep, can you say where you're from? Sorry, I should have asked you to introduce yourself. It's always interesting.
That's right. I am from the George Institute for Global Health in India.
From India. Thank you
Yes.
for calling in. Paula, you have a question? No? Do you want to say it?
Yeah, not a question, but just as Jamlick is saying, he's moving on to understanding from the perspective of people either involving people from LMICs or people in LMICs, being asked to take part in core outcome sets. Understanding facilitators and barriers is what Jamlick is wanting to do next. So if anybody on the call wants to share with him privately in the chat or at the discussion at the end, perhaps.
Okay, thank you. Milan Joshi, would you like to introduce yourself and then ask the question, please? Thanks for typing it in.
Yes, certainly. I was thinking about the use of languages. If you translated the core outcome sets into English and French, how much of Africa would that not cover?
Yeah, well, thank you for that. Yeah, so it's something that initially we had not thought about, but we are seeing it as being a useful tool. If we translate to French, there is quite a huge chunk also from the West Africa that we'll be able to cover. But as we are saying, this was just trying to first understand what could be the barriers in this, and if we do the next step, which is the online survey, and find out that actually probably people say we didn't use this because we don't think it's in a language that we understand, then that can then inform our next steps in terms of trying to improve the outcome of core outcome sets in whichever settings it may be.
So if you have, I mean, I'm thinking of second languages. If you have parts like Mozambique or Angola, they might not, neither English or French are the main language, but would they speak them as second languages in those countries, or would it have to be Portuguese, for example?
Yes, Portuguese, of course, definitely is one of the big languages, given that it's not just for Mozambique and Angola, but if you look at something like Brazil, it's likely to feature. And actually, in one of the study, the diabetes type 2 study, they did translate their material into Portuguese with the purpose of trying to focus on patient participants, but unfortunately, the feedback was not so great. They only were able to get people from the UK and Greece. So it's also some of the issues we are going to just try to take forward and find out why and how then can we make this different.
Okay,
thank you.
Thank you. Any more questions or comments for Jamlick? I've got a big question for you, Jamlick. I think you started off with a statement, I think this is what you said anyway, you can correct me, that said that core outcome sets should be developed globally. So that is a sort of statement that they should be developed globally. And I would question that because there are some diseases where the etiology of the disease is very geographically specific and where the course of the disease is therefore a bit different, and also the treatments are really different. And I'm not sure if the statement should be developed globally is necessarily, I'll just throw it out there, it's philosophical thought. What do you think?
No, actually, it's a very good philosophical thought. Maybe I used the term globally in a very non-sensible way from my end. Globally, in the sense that if you want to have a core outcome set that can be applicable in a slightly different setting, then if you make the scope and the stakeholder range too narrow, then sometimes it can become of a problem. So it was not globally that you have to have somebody from Australia, somebody from Africa, somebody from.
I see what you mean. Okay, right.
Oh, yeah. Sorry for that if it came out that way.
No, I misunderstood myself. Thank you for clarifying. And Chantel Ostler, where are you? And would you like to ask your question? Thank you for typing it in. Chat.
Hi, yeah, I'm from the UK, and I'm particularly interested in core outcome sets following lower limb amputation. So obviously the interventions following lower limb amputation are very rehab focused. And I was interested in whether you think core outcome sets should differ between countries, because with rehab interventions, will social and cultural factors influence what those important outcomes are?
And that's a really good example of something where you might not want it done all globally, but what do you think, Jamlick, for something like lower limb leg amputation that's so different the way it's rehabilitated worldwide, and also the etiology of it, whether it's trauma or cancer or something? Did you have some views, Jamlick, on that?
Yeah, and it's not just that actually, because remember, one of the key driving forces of this is that even health systems capability are quite different across the board in terms of if somebody cannot access the hospital within a given time and you're telling them you have to use that outcome set that was developed somewhere that within 5 minutes I'm in the hospital. So it's, and probably later on in the work, what we'll try to do is to see when you have a outcome sets that had been developed in a given context, how then can you adapt and make it more sensible in your context to be able to make it more useful in terms of what you need to be reporting.
Yeah.
So definitely context issues have to be taken care of. It can be developed overall in a global sense, so to say, but then you might have to sit down and contextualize what is useful for your setting.
Yeah, thank you. Bilal, did you have a question? It says you raised your hand here.
Yeah, I guess we'll have an opportunity to perhaps discuss this further, but this point is very, very important, and I echo what Jamlick says. Reflecting on our experience in gastric cancer, which is a very global disease, there was the thinking that perhaps having a very global, widespread core outcome set might upset some people that will end up having to collect outcomes that they may deem irrelevant to them and their region. I think it really is very much it comes down to how you sell the core outcome set. And that, you know, if you're trying to collect data and compare and contrast in a very broad sense, then you almost have to convince all trialists and researchers that their data tells part of a story. And in order for us to be able to tell that story fully and comprehensively, we need them to collect that information. There was the other aspect, which is, well, if we're dealing with a core outcome set or developing a core outcome set internationally, there may be outcomes that certain regions may prioritize over other regions, and those outcomes might not make it into the core outcome set as a consequence. And once again, the important point to stress is this is a minimum core outcome set, and that there should be additional work which is undertaken locally to identify core outcomes in that region which should be collected in addition to the core outcome set, if you see what I mean.
And then when we've done all that, we can do a cross-cultural analysis of the core outcomes and look to see the cultural differences in core outcome sets.
We've done some of that work. I mean, I'm straying here.
You are straying. I'm going to answer some more questions because you're going to have the floor in a minute. Sarah Gorst has posted something on the chat if you're interested. There's an animation video. Sarah, why don't you explain it, and then we'll come on to Heather's comment.
Yes, so in the Poppy group, we developed a COS animation video explaining what core outcome sets are in plain language terms with the help of public contributors. So I've copied the link in the chat. So for anyone who's interested in developing a core outcome set with non-English participants, that is available in 12 languages at the moment. And as Paula said, we're always looking for volunteers for other languages.
Good. So the animation video is in 12 languages?
The subtitles for the video are available in 12 languages.
Okay, subtitles. Okay, good. Thank you. Heather, who's Heather Bagley now Barrington, I believe. Is Heather, did you want to ask your question? Sorry if I've got your name wrong.
Can you see me? I don't know if you can see me.
I can hear you, but not see you, but there you are. Hello.
No, just wondering, Jamlick, if you're going to be looking at all at any patient and public involvement being used to inform study design in low and middle income countries, especially with engagement issues.
Yes, yeah, we are also going to try and look at that, because one of the works we are going to do within this PhD work is try to do a outcome sets with that will have to involve some patients in the area of neonatal care. So yeah, that's also something that we're exploring in terms of getting information on that. Heather.
Good, thank you. And Paul has emphasised that you're always looking for volunteers for more translations of the video. There are lots more languages than 12 in the world. And somebody from experimental medicine has said how useful the core outcome set animation video is for their dysphagia study in critical care. So that's good to hear that. Thank you very much. And thank you again to Jamlick for that presentation. We're going to move on now to Bilal, who is a surgeon, upper gastrointestinal surgeon from Manchester, who has completed his PhD, which was recently examined. Well done, Bilal. Supervised by Ian Bruce and Paula Williamson and others. I was a little bit involved, and he's going to tell us about some of the international language translation issues. Thank you, Bilal.
Thanks, Jane. I want to cover two things really. Yes, the translation aspect of Delphi's, but in a broader sense, I want to perhaps touch on key strategies or considerations when it comes to making core outcome sets international. We're going to be using the case study of gastric cancer surgery, which is the basis of our core outcome set, which was developed. And as you can see, there's no presentation about international consideration would be complete without a world map of some description. And you can see here the incidence of gastric cancer is spread out far and wide across the globe. And that really was the basis or the motivation for trying to include as many opinions and stakeholders as possible from around the world. So I've got two questions that we perhaps need to just spend a little bit of time talking about. Firstly, what makes a core outcome set international? We talk about international core outcome sets. Not all core outcome sets that claim that they are international are in fact so, and we need to define clearly what we mean by that. It might be that the core outcome set is used internationally by trialists. It might be that the study team included international stakeholders, and it might mean that the stakeholders which were involved in seeking consensus were from international regions. So we have to be very careful what we talk about when we talk about international. What I'm going to be focusing on here is all three, and hopefully we can demonstrate that our core outcome set ticks all three boxes. Jane's already mentioned this point already and asked this question: does your core outcome set need to be international? Is there a reason for your core outcome set to be international? And to answer that question, you need to go back to the basics. You need to understand what the scope and the setting of your core outcome set is. And the easiest way to do that is to go back to the COS recommendations in describing what your core outcome set is about. There's several aspects of those recommendations that can help you answer the question whether or not you need an international core outcome set. The other point that we're going to be talking about is the translation or an approach to translating Delphi's. And again, you have to ask yourself your question: just because it's international, does it have to be translated? And again, it depends on where from these international regions your patients or your state healthcare professionals, stakeholders come from. If they are from regions which speak languages other than English as their first language, then there is a strong argument to do some translation work there. So which parts of the process of developing a core outcome set can be internationalized? And this is the GASTROS, which is a gastric cancer surgery core outcome set. This is quite a broadly accepted method of developing core outcome sets. And there are three main areas you can internationalize your core outcome set. In stage one, when you identify potentially important outcomes, you can do some of the patient interview work, the qualitative research work to identify potentially important outcomes. That can include patients. The Delphi survey, which we'll be focusing on today in this talk, and of course a consensus meeting to finalize the core outcome set and the final outcomes to be included. That can be international as well. So moving on to the key considerations, these are lessons and strategies that we learned from our experience in developing a core outcome set in gastric cancer surgery, and we'll be going through each one at a time. We can perhaps talk a little bit more, delve into a bit more detail in the questions and answers if people are interested. So the first area was the development of an international working group, and the importance of this is really that it's all in the setup, it's all in the preparation. The adage about preparation prevents poor performance is very important here. And what we did was we set up collaboration groups led by a regional collaborator in each country, and under that lead collaborator, there was a team which was working very closely together. And that team and the collaborator was responsible for the translation work, developing networks for recruitment and dissemination of the study, to drive recruitment when it dipped or when it plateaued, and then finally to obtain any ethical approvals that were required. And it was very important to set out terms of reference so that everybody knew where they stood, what was expected of them, and of course we included what their role would be in the outputs from the study as well as their reward for participation. Patient participation is another key consideration. Patients were involved in our study advisory group to ensure that the aims and objectives were being met from a patient perspective. Patient participation was very, very important in the recruitment stage. When we were recruiting to our Delphi survey, we relied heavily on groups and patient charities to put out the word to help patients participate and recruit to the Delphi. The development of the Delphi survey, which we translated and ran internationally, was very, very important to involve patients in the process of developing the items for the Delphi. We needed patients for the cognitive debriefing aspect, which essentially is a fancy way of saying that we need to make sure that the items used in the survey are easy to understand and are clear. And that was especially important because when you're translating items from a Delphi survey into another language, we need to make sure that the original items are clear so that there's no mistranslation of items. And of course, patients were important in the piloting of surveys. Translators, which translators should we use? That was something that we thought long and hard about. We considered using professional services, but because of limited funds and resources, we opted to seek the support of healthcare professionals with a background in core outcome set development or outcome reporting and understood the field to help us with the translation. One of the things that we'll be talking about shortly is the criteria which need to be met by any translator, whether professional or healthcare professionals, and these relate to both the forward translators and the back translators from English to foreign language and from the foreign language back to the English language as well. And as I said, the main issue here was cost for us, but it did affect the speed at which the translations could be delivered. So that's another key consideration there. Timelines are really, really important. It's, I mean, I'm saying it's really important for every point, but you need to make sure that you have clear timelines. It's really, really imperative. And the more languages and the more translations you're going to have and the more regions you're going to try to involve, the clearer and tighter your timelines have to be. You need to take that into consideration, particularly if you're going to have a 3-year PhD program or you're even running a tighter timeline than that. You need to know, give yourself plenty of time to make sure that you can recruit in all these regions. The main impacts on timelines was the parallel translation work that we undertook, waiting for people to get their translations back. Ethical approval also took a significant amount of time, waiting for committees and reviews of initial applications. And then the local recruitment, it varied significantly from region to region, and there were many reasons for that. which we can go into later. So as an illustration, you can see here, so document prep took a couple of weeks, and then the time to return the completed translation for round 1 of the Delphi survey varied from anywhere between 2 weeks to 18 weeks. And that's with 7 translations. So imagine if you want to run even more translations, that's going to be even more of a problem. If you see here, time to obtain ethical approval, that varied significantly, again from 2 weeks up to 40 weeks. And it's very important that you try and begin that process as quickly as you possibly can. You need to set your recruitment targets very early on. Initially, we had aimed to recruit 100 people, and due to a snowballing effect, and we were pleasantly surprised to see how popular the study was, and in the end, we managed to recruit nearly 1,000 people. You need to understand what your retention targets are going to be. Are you going to aim for 70% retention between rounds, 80%? Because that will determine how long your second round is open, and that will affect your timelines as well. So round 1 was open for 12 weeks, round 2 was open for 13 weeks, and 70% retention was achieved in our survey. And just to give you a summary, 952 people were recruited in round 1. 637 people used translated surveys, and 350 used the English language surveys. And you can see there were periods where there were plateaus or slowing down of recruitment, and that sped up, spurred on by dissemination and more advertising from the study group. Not everybody can use an online Delphi because online literacy levels vary internationally, not just LMIC countries, but also HICs, depending on what the patient group is, whether the elderly patient group that you're trying to recruit. And for us, it was important to try and obtain or include as much opinion as possible. For the online Delphi survey, we used Delphi Manager because the servers were not restricted. So you have to bear in mind that some countries restrict certain domains. Some of the kind of widely available platforms may not be accessible from certain countries. Delphi Manager was able to utilize or to present all kind of language characters, so there was no limitation. And it also sent automated reminders, so that was the benefit of using Delphi Manager from our perspective, and that's been developed by COMET. It was important for us to include paper versions, which the local teams uploaded on behalf of the patients, and that increased patient participation in China, Nigeria, and Turkey in particular. How have we maximized recruitment? That's another consideration. Well, there's lots of strategies. We don't have time to go into much detail here, but disseminate wide and far, use social media, local recruitment. Don't just think, well, we're going international, let's forget about our local clinics. Don't miss that opportunity. Associations, patient groups, charities. It's very important to set up wide networks of these groups from an early stage, and we endeavoured to do that right from the very beginning, way before the Delphi survey. Personalised emails were important, particularly to certain healthcare professionals, and I'm sure we've all been inundated with Delphi survey requests, and we're all fatigued from participating in Delphi survey after Delphi survey. So personalised emails add a nice touch. And social media and multimedia were very important. So we had 3 areas there. This is our website, which kept everybody updated. This is the YouTube channel where we developed some explainer videos about the study and what core outcome sets were and how to participate in the Delphi survey. And then finally, Twitter was instrumental as well as LinkedIn in recruiting people for the Delphi survey. Ethical approval, we've talked about before. Requirements vary for ethical approval, surprisingly. Even in the UK, there's no standardized approach to ethical approval for core outcome sets or Delphi, so you need to bear that in mind. We were asked to provide a full ethical approval application. Some of our colleagues in other core outcome set developers were asked to proportionately or submit for a proportionate review. and some colleagues weren't asked to do any ethical approval. So that's something to bear in mind. We've talked about those timelines. We've talked about why ethical approval might cause timeline pressures, and as I've said, that was the biggest timeline pressure from our perspective. Costs, finance is always important. Translating using a professional service back in April 2018, when we were considering it, cost anywhere from about £3,000 to £4,000 per language. We simply did not have that amount of money, but in exchange for that, you get your translation back within 4 weeks. So that's something to consider. Ethical approval, some countries charge for you to submit ethical approval. So one of our countries, Ireland, wanted £250 for an ethical approval application. Lots of other costs there we can talk about later, but Delphi Manager has some costs and statistical support when it comes to analysing the data. Translation methodology, we'll run through that quickly. How long do I have, Jane?
You're a bit over time. You've got minus 1 minute.
Minus one, okay. Two things, and I'll talk about what has been done before, what did we do. We can only find 4 studies which had translated the Delphi survey, and what we found was that the methodological approach to translation was inconsistent. And we also noticed in a lot of these translated Delphis, there was poor uptake from the translated survey. We developed our own methodological approach based on international guidance in outcome reporting, how we should translate various aspects of work related to outcome reporting, 10 steps, which we can talk about later, and we'll be hopefully submitting for publication imminently. We don't need to go about that. Let's talk about the results of our approach. So the key considerations and the strategies that we employed, in addition to translating, resulted in nearly 1,000 participants, lots of patients, lots of surgeons, lots of nurses, and importantly, lots of representation from LMIC countries, which we're talking about today as well. 55 countries, 6 continents, and also importantly, loads of people use a translated survey, which wasn't the experience with other groups that had translated. 62% of patients used it. 69% of healthcare professionals use translated surveys, and in those regions who are given a choice between the local language and English, the vast majority of people obviously chose to use their translated versions. Consensus meetings, well, we won't talk about that, we don't have time, but you need to think about how you're going to internationalize that. Lots of work needs to be done there. So finally, these are just some of the people who were involved in our core outcome set from across the globe. And thank you very much. Any questions?
Thank you, Bilal. That was very interesting. Covered a huge amount. Can you stop sharing, Bilal? Is that all right?
Oh, yes.
We can all see everyone. So we have some questions on the chat. Let's start with, put them in order. Paula, did you want to ask your question?
Yeah, hi Bilal. It was just whether or not you could say a little bit more about engagement with patient organisations around the world. How did you do that? Did your international colleagues do that? How did it work?
Yeah, so there's a mix. So for the English language charities and groups, I did a lot of that myself. I contacted the charities and patient groups myself. For the more non-English charities, the patient groups which we use, and there were many of those, it was primarily down to the local collaborators. And that's why it's important for you to outline right from the start what the responsibilities of each of those lead collaborators will be. And we made that clear that it would be important for them to develop their own network of patient and healthcare professional groups and links from which we could recruit.
Thank you, Paula. And we have a question from Amber. Do you want to introduce yourself as well, please?
Yes, I'm from Bristol. I've completed a core outcome set in burn care research. Bilal, thank you for your excellent talk. We had in total 700-ish participants in the Delphi, of which a third were from low and low middle income countries, but they were all professionals. We would have loved to included international patients, but it was the ethical issues that stopped us. How did you find getting through ethics committees particularly in low and lower middle income countries? Did you need to?
So our experience, yes, we did. Our experience was varied. The 2-week ethical approval country that I presented was an LMIC country. The 40-week ethical approval country was an LMIC country as well. And our experience varied. There was one group where we just simply were unable to get ethical approval. And we just had to proceed. So you have to take an executive decision, and at some point you're going to have to decide whether or not you're going to be able to incorporate participants. But we did have good representation from LMIC patients, not as much as we would have hoped for, but we did have.
And did you coordinate that with a local clinician?
Yes. They were key. The international working group, local collaborator was key to all of this and to recruitment.
Thank you, Amber. And Venica
Sorry. No, that's okay. Thank you very much. I'm from Amsterdam, Amsterdam University Medical Center. Thank you very much for a very nice presentation. I was wondering if you have if you also translated like comments that patients gave or quotes, and how difficult was that?
Yes, we did. We translated those, and again, that's the importance of having a local translation team working with the collaborator. And we knew we were going to do that right from the outset. So the team were expecting, were expecting to translate the comments left in the Delphi survey. They were extremely rich, and we actually collaborated with a couple of other groups who have developed core outcome set. We've recently just published a paper with Paula and anal cancer and prostate cancer group, looking specifically at comments left by all participants, including patients, trying to explore why they changed their minds between rounds. So we can certainly provide you with the details of that.
Yeah, it would be very interesting. Thank you.
And Bilal, Sally Ann from Belfast would like your email address, please, for you to send it.
Yeah, I'm happy to provide that.
I have a question for you about your definition of international, which I liked. I wondered if you'd looked outside medicine for definitions of international.
I haven't. However, during our systematic review of the COMET database to identify those that had translated work, we identified over 100 groups that had kind of claimed themselves to be international, but only 4 had used translation as part of their methodological approach. So whilst that gives us a bit more information as the broader definition of what international may be, I certainly haven't looked outside of medicine anyway to look for definitions.
It's always interesting to do that. I had a little message saying 2 hands were raised. Did somebody who raised a hand, I can't see who it is, want to speak, please?
Hi, Bilal, Shamadip here from India. I'm actually in the process of trying to scope out core outcome set development. So thank you for your presentation. It's really useful. I am just wondering if in terms of the actual outcomes being selected where more global participation is there any analysis of how different they are actually between different regions of a country? And I mean, so it's essentially an opportunity cost of cost benefit, how much international do we go? Because more international we go, the more resource intensive it becomes. So just wondering if you have any reflections.
Yeah, so excellent question. Absolutely, we have looked at that. The fact, because we were able to recruit such high numbers to the Delphi survey, we were able to undertake an analysis of regional variation and variation of opinion and priorities between LMIC and HIC countries, HIC settings. In our case, we found that there was not significant variation within stakeholder groups. So when we looked at patients, when we looked at surgeons, when we looked at nurses, there was not wide variation when we compared low to middle income country priorities versus high income country priorities. And similarly, I mean, we have an east-west divide in gastric cancer, in etiology, in management, etc. There was no significant variation when we compared surgeons from different regions or nurses from different regions and patients from different regions. So that still needs a lot more exploration. That's only just one case study within gastric cancer. I hope it creates the motivation to explore matters further. But what it has done, it has coloured our approach to the next stage when we come to identify outcome measurement instruments for the core outcome set. I plan to be a lot more focused and narrowed so that we can get things done in a bit of a quicker time frame.
Thank you both. And Sarah Ibrahim, would you like to ask your question?
Yes, hi, my name is Sarah Ibrahim. I'm part of a US-based group in dermatology core outcome sets. Thank you so much for your presentation, Bilal. So we are hoping for our personal core outcome sets in dermatology are looking to develop an international core outcome set involving a wide variation of countries. And so one key question that we've considered is how to hold the final consensus meeting and then collate the results from those. So I'm curious as to what considerations you've had if you've already held that meeting or if you plan to hold that meeting. How do you make sure to still involve key international representations?
Yeah, so so we have held the core outcome set consensus meeting, and then there's 2 points here really. Number one is a question of pragmatism, and how much time and resource you have to invest in that consensus meeting. That consensus meeting, from our experience, because we were able to involve so many stakeholders from across the globe, the final consensus meeting did not add any additional outcomes. However, what it did do was identify some further area of work, particularly in the reporting of serious adverse events and complications. So our experience was that the core outcome set consensus meeting was held in English. That naturally excluded certain stakeholders, particularly the patients. And that was a limitation and a weakness from our consensus meeting. But we had to make that decision, how would we do that? One approach may be to hold a number of consensus meetings in different languages, and then do some kind of final consensus meeting, if you know what I mean. So that again needs a lot of hard work and resource, and again, it identifies further areas of research and demonstrates why core outcome set methodology is really still in its early phases, and there's so much more to do. I can't really give you an answer to your question other than just to share with you our personal experience and what we did.
Thank you, Bilal. And Paul has added, Sarah, a comment on the chat about a workshop that's being convened that you might find useful for this. So, Paul, I'm not going to do your last question because we've got to the end there, and I'm sure you can ask that of Bilal offline. But I would like to thank Bilal and thank Jamlick for their presentations, and thank you to all of those of you who've asked questions, and to Sarah who's organised it. And we're very pleased with how these COMET webinars have gone, and we look forward to doing similar things again, or meeting you face to face next year. And we wish you well, and thank you for your time.
Thank you.
Bye.
Hi, Sarah.
Hi, Paula.
That was really good. It's really good.
Yeah, it was great.
Yeah, I think it was about half, wasn't it? What did you say the numbers were? About 120 registering.
We had 126 and we got 67 we had attending today.
Yeah, yeah.
So
It's
just
weird, isn't it? It's almost consistently half.
Yeah, I thought the earlier ones might have been a bit different and you get more for the later ones because there wasn't such a gap between them, but
yeah,
things come up.
But I mean, I'm looking at all the names and they really were people around the world. Do you know what I mean? It's really interesting. It's not the people who've developed their core outcome sets who didn't include people from elsewhere, you know? So
yes, I think there'll be a lot of people that who will go on and use the tips and things and the information, so that's good. And that's the good thing about the online webinars. You wouldn't get all those people attending if you had it in face-to-face.
Exactly. Honestly, I really am trying to think. It may be just we're all institutionalized in being on Zoom and that we only see the benefits of the online stuff now. Do you know what I mean? But
yeah,
I am struggling. I'm comparing it to some. I mean, you know, some of the ones in Amsterdam were absolutely fab, but that one in Calgary where there was all that uneaten food. I mean, that I just can't forget it. Do you know what I mean?
I think it's the cost, isn't it, for how much you have to spend to have a face-to-face meeting. I think it does for people to network and to get to share tips and things with each other. I think that really helps.
Yeah. Oh, someone's coming back in. I do. I think it'll be it'll be interesting. We can chat about it in the COMET management group because we wouldn't be doing something next year anyway. It'd be the year after. Yeah. And I'm wondering whether we just put something alongside the Harrogate trials.
I was going to say that'd probably save a lot, wouldn't it, if you could do it, and you probably get a big chunk who'd be going to that anyway. So
yeah,
save on fees.
Right, I need to get into my 2 o'clock. Anyway, good. It was good.
Okay. Great.
Bye.
See you, Paula. Bye.